Welcome, everyone. We're so glad you could join us. This is our briefing on the Southern California wildfires. Today, we're going to discuss our response and our ongoing work as communities recover, as well as our efforts to build resilience against future disasters across the United States. Welcome again. I'm Rebecca Milner, International Medical Corps' Chief Advancement Officer, and I want to thank you for joining us today. Many of you on this call have supported our work over the years, and we can't thank you enough. Your commitment makes everything that we do possible, and we can't do it without you, so thank you. Some of you are also joining today's discussion in lieu of this year's in-person spring luncheon. We decided to skip it this year because of the wildfires and how it impacted the Los Angeles community. And we want you, to know that we are really thinking about you, and we know how close to home this emergency was, and our hearts go out to everyone that was impacted by the fires. So thank you for being here with us today. Before we get started into our discussion, I have just a few quick housekeeping notes. For the first part of today's discussions, guests will be muted and off camera so we can kind of keep the conversation moving smoothly, but we absolutely encourage participation. So feel free to use the Zoom chat and Q&A box to enter questions anytime. And then you can also raise your hand, and toward the end of our conversation, we'll turn the cameras back on and take as many questions as we can and try to get through as much as possible. So we'll definitely leave time for some conversation among all of us. So today, I'm really pleased to welcome two of our colleagues here at International Medical Corps. We have Erica Tavares, our Senior Director for U.S. Programs and Advancement, who's been leading the wildfire response, and Sue Mangicaro, who is a nurse and our team lead, and she's been instrumental in mobilizing our incredible team of responders and has deep experience responding with us over many, many years. So I'm really looking forward to our conversation. Thank you so much for both of you for being here. Erica, we'll have you kick it off. It's been just 4 short months since the Palisade and Eaton fires first broke out. Why don't you kind of give us a brief reminder of what the early response looked like and how International Medical Corps responded?
Sure. And thank you so much for having both Sue and I here. And just again, want to thank everybody on the call today. As a Los Angeles-based organization, it's we were honored to be part of our response and to be able to give back to a community that has been so generous with us globally over the years. So thank you for that. So International Medical Corps deployed right after the fires broke out. Within about 24 hours, our team was on the ground. We were working with our health center partners. We were contacting sort of the response coordination mechanisms, and really seeking to understand how we could plug in, how we could help support response efforts. Part of what was a challenge for this response was that the fires themselves were burning for so many weeks while we were still responding to individuals and families who were displaced from their homes. And so it made for a real challenge coordinating, figuring out sort of where the needs were greatest and how we could help. We were incredibly fortunate. We were able to deploy 58 medical and mental health, mostly volunteers, clinicians, who supported our response efforts. And we partnered with the American Red Cross to be able to provide medical and mental health care both within the shelters. So we were at the Pasadena Convention Center providing care. We were at the Westwood Recreation providing care. And when the Hughes fire broke out, we were the only medical and mental health team that was sent with the Red Cross to be able to support any response that was needed for that community as well. And so throughout, we worked very closely with Kaiser Permanente and with Altamed, who were also providing care within the clinics. After the first 2 weeks, our teams were really able to take over to allow those local doctors and nurses go back to their job and continue supporting the community through their regular offices. And we were brought in to help provide medical care, but we were also brought in because there was a very somewhat unique circumstance in this response, where because the convention center and the shelters were open for an extended period of time, we actually saw a number of disease outbreaks. And so we helped to set up isolation facilities to address outbreaks of COVID-19, norovirus, flu, as well as scabies, which is always one of the ones that really gives people the ick. But we were able to help get those under control and really leverage a lot of our experience globally in setting up these kinds of isolation units, being able to provide care when you don't have all of the tools and resources you need to keep people safe, keep families safe, and keep them as comfortable as possible in those circumstances. So we did provide, oh, go ahead, Rebecca.
Well, I was just going to say, I mean, you mentioned that it was really challenging because the fires were ongoing for 3-4 weeks, but it was also challenging because it was such a wide geographic area as well. Maybe you could talk a little bit about that and the implications for how you coordinate and provide support when it spans such a wide area.
Yeah, no, thanks. So we were able to launch a countywide response because of the amazing medical and mental health teams that we had, and because we did have such a sort of interest in supporting this response effort, and because of the resources we were able to mobilize. And so we were working with the county and the California Department of Public Health, who was one of the leaders in kind of organizing the response. We were also working with LA City. There was a dynamic there where there was both a response required within the city and then within the broader county. And then, really working at community sites. And so, working very closely with those responders, with those response organizations to make sure, as the needs shifted, as communities opened back up, we were not only in the shelters, but we were able to have our mental health teams go to the reentry points. Some of you, I'm sure, have seen that the reentry point at Santa Monica Pier, our teams were there to really help provide information on mental health, how you might be able to cope as a family affected by the fire, what resources were available, and what you might see when you go back for the first time to your home. And so we were able to be there and really on the ground with communities. And because we were so mobile and we had these mobile units, we were able to move around very quickly and be very flexible based on where the needs were, how they shifted, and what the situation demanded.
So you mentioned a lot of our partners, whether it was a Red Cross or Kaiser Permanente or Altamed, but when we're involved in something that's this large and you're coordinating, I mean, you're also working with state and local officials, right? To identify the roles and responsibilities each emergency team would have, right?
Yes. Yes.
Okay.
So in this response, so normally there's an emergency operations center, and there was an emergency operations center, which is run by the state and by CAL FIRE, who we did coordinate closely with. But they were really almost solely concentrated on the fire outbreak itself. And so we worked with them, but then we also were working with a number of other coordinating bodies. So we worked certainly with the leadership at the Pasadena Convention Center and the Red Cross, who was supporting the coordination of the shelters to find out where we needed to be. We also worked with an organization called the California Primary Care Association, and then their sister county association that organized community health clinics. And so we were able to really work with them and through them to find out where the clinics were that needed the most support and how we could best support not only families affected by the fire, but the health workers themselves. One of our partners, Altamed, who's a fairly well-known health provider in the county, actually lost a clinic. They had dozens of their staff that were displaced. And when we talked to them, while there was a lot of outpouring for their patients and the communities they serve, they were really struggling to be able to help their health workers get back on the job. And that's something, as International Medical Corps, we're really familiar with that. We've seen that all over the world. And so we really were able to focus our resources and provide over $400,000 worth of support in housing stipends and rental support and critical supplies that helped health workers get to a place, be able to have housing and get back to work, which was also a gap that was really identified. And so over the course of the response, we worked with 16 different organizations, whether that was, the Red Cross or LA City or County and some of these smaller clinics. And we distributed over 80,000 pieces of supplies, critical relief items across the county through these partners, as well as providing the direct medical and mental health services.
Amazing. I mean, it was amazing not only to mobilize nearly 60 volunteers, but also to provide all of that support for our partners and affected community members. Well, Sue, I mean, you were on the front lines of kind of coordinating this kind of incredible response with these amazing volunteers. Maybe you could tell us a little bit about how all of that works. How do we recruit and then deploy and then manage these volunteers that were there for, well, 3 or 4 weeks, right? It was a significant response here in the United States, which usually with these disasters, it's a shorter time frame, right? Maybe you could speak to both those questions.
Sure, sure. And first of all, thank you for the opportunity to kind of share my experiences. Well, is trying to bring forth some of the experiences of the volunteers who basically they're kind of the heart of the organization, right? I think
Right.
when I think about the volunteers, I think it's hardwired in their DNA, it's hardwired in our DNA to basically make the lives of those suffering better. So that was no different here. Let me talk first about a little bit about the volunteers. And yes, you are absolutely correct. It's typically a 2-week approximate time frame when there is a disaster, often in a hurricane per se, let's say, or floods. We get the system up and running within 2 weeks. It's that immediate week or 10 days after that our help is needed the greatest. This was very different because of the dynamics and the scope of the disaster itself. The volunteers, so it was an extended period of time. And many of the volunteers, the beauty of it were repeat people. These are
Mhm.
folks that have been on deployments with us over the years. They've gone global, they've gone to disasters in the US. And it's kind of heartwarming when we get together for the first time, when we bring the team of people together, because we were there 24 hours. We'd have debrief meetings twice a day. In the first meetings, when everyone sees who's there, it's like homecoming. We're all so happy to see each other and reconnect with people that you might have deployed to Haiti with in 2017, or maybe you were in Hurricane Michael in Florida in 2020. It's people that have those connections and those bonds because we've done this together before. And the other piece that was really important with the volunteers is we have a roster of names of folks, and we have agencies that we're connected with that provide those staff for us. We vet them, we train them, we make sure that they know what to do in the circumstance that they're going to be in. And the beauty is when they return, they know our process, we know them. We also enjoy bringing new people in because now you can train them as well. And at the end of their deployments, the interesting thing was several of the staff, the doctors, the nurses said, please make sure you give me a good review because I really want to come back. That you're doing the right thing. And, you know, I joke about it, but it's really important because these are the frontline caregivers of the most vulnerable people from the disaster. And those are the people that you want front and center representing what we do as an agency. And that is provide the best care, make their lives a little bit better every single day. A couple of the volunteers do come to mind that like folks might know, and one is Dr. Michael Grady. He was a recipient of our award last year, and Dr. Grady has worked with us and volunteered with us time and again in Gaza most recently, and he may still be there, I'm not sure, in Myanmar. He responded last year in his own backyard for Hurricane Helene when the floods in Asheville destroyed much of that region. Dr. Grady was our medical coordinator and truly just a joy. He's absolutely a wonderful human being and a humanitarian, and he was there. Another name that folks might recognize is our amazing superstar nurse, Yvonne. And Yvonne was a speaker last year, I believe, was it, at this luncheon?
Yes.
2 years ago at this luncheon. And Yvonne was our nurse manager and just is so passionate and kind and dedicated. She came back. People that
Right.
were there for 2 weeks extended their stay. And when you think about what they're doing, in other disasters, you might have, or the audience knows we do conflict zones. We do major disasters where we're first on the ground. They might have mass casualty. They may have wound care in like a very busy emergency department. This is different. Shelter care is different. The need is very great. Erica talked about, us setting up an isolation unit. You have shelters where there are hundreds of people that are displaced, and all of a sudden outbreaks occur, and they knew they could rely on International Medical Corps because we do infectious disease outbreak. We were very rapidly able to, with a team of doctors and nurses that are trained, put process in place to have that isolation unit to cut down. Within a few weeks, we went from it being full to closing it down eventually because the process was put in place. And so some of the roles that the staff serves is not just clinician, not just physical health, but it's mental health as well. And we did have, sorry.
Well, so you mentioned we had doctors, nurses, and mental health professionals. I mean, and that's mostly the mix that we have, or how, so like if a shelter team is there, what did that look like?
Sure. So we had two major shelters, the one in Pasadena and the one in Altadena. And then we had the reentry points that Erica mentioned, as well as the mobile medical teams. The teams that worked at the shelters were round the clock teams, so more staff during the day, less in the evening. We'd have.
It was 24/7, but it was 24/7.
Correct.
Okay.
Correct.
Right.
Eventually we decreased as the number of
Needs.
residents decreased, and as we try to get back to kind of normal life. So we would have at least a doctor or two, as well as nursing staff at each site, and then mental health would be incorporated as well. And so we worked very closely and cohesively with that group of folks, kind of supporting each other and providing that psychosocial help, not only by mental health, but also by the medical staff as well.
And then both the shelter teams as well as our mobile medical team, what were some of the medical needs that existed? I mean, so you're displaced from your home, you've lost everything. What do people need health-wise?
Yeah, health-wise, very often there's a couple of things that occur. People go back into their area, their home, and they may or may not have a home, but they start to rummage around. Very often there are cuts and abrasions. We had falls, people that would present with, I just came back, and they'd fall and scrape, or we had casting and that sort of thing for wound care. We also would see folks that needed prescriptions renewed. So we were able to kind of coordinate with the state as well there, because people do run out of your prescriptions. You have no notice, you have no warning, you have to just leave your home very quickly. Those were some of the things that we would see. The other thing, honestly, was, again, the psychosocial support. Sometimes they just wanted to stop in and kind of chat, have their blood pressure taken, check their blood sugar. A diabetic that might not have their equipment with them to do a blood test. So that would be the other type of thing that would be done. Just basically, chronic care and supporting their need for what they were missing, because they're so busy with trying to get back into their home or figure out where they were going, because many of them did not have a home.
Right. And on the mental health side, and this is both for both of you, Erica and Sue, not only did we provide direct services, but we helped kind of collect and share information and communication, right? Because so often when these emergencies happen, just everything breaks down and you're just feeling isolated and alone, right? And so not only is it providing direct services, but it's also like giving people access to information, right? I mean, I think that's one of the things that we say globally: information is aid, right? So maybe Erica, you could talk a little bit about that.
Yeah, absolutely. So, and I'm sure people on the call here have felt this, but when something like this happens and so many people are displaced, that social fabric, that kind of where you go for whatever it is you might need, your doctor, your mental health care, your schools, all of that starts to break down. And that, kind of creates its own sort of mental health need. And so part of what we do, and to your point, we do it globally, is collecting information, being able to provide people with easy to access links, information, some really, sort of targeted exercises to help people sort of cope and manage and de-stress. Because when you're able to do that, when you're able to sort of maintain, less stress, or more of an equilibrium, you're able to sort of recover better. You're able to access that information better. And so we did collect information. We had a regular process to make sure we had an understanding of what were the hotlines, where was the available services, how do we direct individuals to places? And that was information that we were giving out through our mobile teams and at these reentry points. And it was picked up by LA City and Cal Fire and used in their own outreach, because they saw, that it was helpful. And that is something that we've learned from our colleagues internationally, that, part of what they will often say is mapping available services or referral services, but it's really understanding what resources are out there, and giving it to people who've been affected in a very comprehensive way to make it easy. And then, being able to put that up on our website and our own social media, so that, people who are coming to us had really easy access to that information.
Yeah. I mean, Sue, is there any of the patients or any of the residents that we encountered, any of their stories kind of stick with you, or that you heard from the volunteers that can kind of bring it home to everybody about how this impacted everyone?
Yeah, one of the stories that kind of stuck with me is one of our emergency room nurses. And by the way, all of the doctors and nurses, the vast majority, something I forgot to mention, were from California. So it was really meaningful to them. The vast majority were from the state of California. Many of them had individuals that were impacted. But a couple of the stories that come to mind, one of our ER nurses from Northern California, she's deployed multiple times with our organization. And she said during our debrief that this was the very first deployment in all that she's done, that she was literally brought to tears. And she said by one of the folks that were in the shelter, one of the residents, who had shared with her how he had saved his entire life to buy his home. And that was his like pride and joy. And he lost it. He lost his home. He lost his vehicle. He lost everything. He had to leave, like most did, very quickly, and lose everything. And he was so proud of having had a home in the first. And he was like, I don't know where I'm going to go. I don't know what I'm going to do. I don't have insurance. I'm not able to do anything. I don't have the money to rebuild. And that was a story that we heard over and over again, kind of from our volunteers, is the stories of people that had homes like passed down generation to generation, that can't afford to rebuild because it's too costly to rebuild. Yeah. They can't afford to move, but their workplace is still in the impacted area or in that region. So that was the part, I think, that like really stuck with myself and the staff, and in the reward of like being able to be there to listen. And that's a huge, we fix phones, we do the medical stuff, but that's such an important part of this work. And I think why they said it was so rewarding, and like we all understood, and why everyone, shelter work sometimes gets a bad rap for, oh, it's so tedious, it's hard, it's terrible. But the meaningful role that we play in shelter work is more rewarding than, I think, from what the staff would say, than most other. So those were kind of some of the stories that really, I think, took us all home and meant a lot. And the fact that, people kept re-signing up, or they'd go home and come back. And it it was fabulous because you know that the reward was so great for the work that they were doing. They knew that they were making a difference, and they'd go out of their way, like, oh, today we're going to be able to wash so and so's hair, help, the elderly
Right.
or the
Sure.
to
Yeah.
do things just to make their lives a little bit better.
A bit better. Yeah. Well, I mean, clearly recovery is going to take months and years. And Erica, maybe you can talk, I mean, because our job in the LA area is not done, right? To
Right.
help with recovery efforts and our particular focus on ensuring the strength of the health system within, the affected communities. Maybe you could talk a little bit about the recovery efforts that we're working on and how we're going to be continuing this work over the coming months.
Yeah, absolutely. And it is going to be, I mean, we know anywhere that we work that recovery is long term. And so we are very much committed to continuing to strengthen, as you say, that network. And so we are working with a number of community health clinic partners, Venice Family Clinic, I know many people know, Pacific Clinic, others. And we're doing a couple of things when we work with these partners. First, we're continuing to provide surge support for ongoing care. So as people have moved and shifted, there are some organizations and health facilities that are seeing spikes in need and care, whether that's because there's new people that they're caring for, there's an increase in or a shift in homelessness populations, there's an increase in types of health services or needs. And so we're working with them to really help fill those targeted gaps. So for some of our partners, that looks like providing the resources for an additional mental health provider for the next year to really meet that increase in demand. For others, it's continued providing housing support for some of their healthcare staff so that they can consistently be on the job, or helping them to pay overtime for healthcare staff who are now being used to go out into communities, because as people have moved and they're not coming in for these regular appointments for their chronic disease management, our clinic partners are sending their doctors and nurses out into the communities to be able to do home visits. So we're doing things like that just to continue to provide the level of healthcare that's required for communities that were affected, whether you were affected by a fire or you live in a community that wasn't, but is seeing an influx of new residents, which again is a dynamic we know worldwide, that when people move and are displaced, it really strains resources for everybody. And so we're working to really ease that and ease that resource need and cover those gaps. But we're also working to really strengthen sort of the resilience and response capabilities of the healthcare system. So, we're the community clinics that we often work with are not designed or set up to be emergency responders. They are very community-based clinics. They provide primary healthcare, chronic disease management. And when something like this happens, when there's a disaster of the size and scale, they are expected to respond and become first responders very, very quickly. And so we're working with over 30 organizations, health facilities, and clinics throughout LA County this year to provide a series of training to help them develop emergency management plans, to help them identify what the risks might be. We found both in California, but really across the United States, that if our clinic partners are ready for a disaster, it's a very specific type. If they're in Florida, they're ready for a hurricane. If they're in the Midwest, they might be ready for a tornado. But as weather becomes more severe, as the disasters become larger and last longer, things are changing. We're seeing ongoing flooding, across the Southeast. We're seeing these wildfires and the extent of these disasters. Wildfire season really lasts all year long. And so how do you not only prepare for the specific disaster you might be used to, but how do you really start to think beyond that and think more flexibly about what response and resilience and getting back online and keeping your doors open looks like? And so we're doing that. We have a series of trainings set up in Los Angeles throughout the summer and into the fall. But then it's certainly something that we're also doing in North Carolina with community clinics and partners who are recovering from Helene. We run an annual summit every year with our partners in Florida to really think through emergency management. And this year we're looking at not only hurricanes, but heat and the impact of heat and how you can make sure that, in a heat wave or a hurricane plus a heat wave, that you have the infrastructure to keep the clinic open, and you're also preparing your patients to stay safe. So we're really expanding that breadth of work, and we're finding that there's just really, both within California, but also nationwide, no limit to the demand. The demand is far outstripping the resources. I think we've got something like 45 trainings for 76 clinics over the next 3 to 4 months
Wow.
that have already been scheduled, and we're getting more and more every day. Um, in
What,
California,
so
yeah.
can I ask though, why should local healthcare clinics be ready to respond to emergencies? Maybe talk a little bit about that gap that exists in the United
Sure,
States.
sure. So, historically, healthcare, while it's been part of an emergency management plan, it has largely been the responsibility of hospitals and hospital networks, with the idea that an emergency would happen. There would be a rapid and acute uptick in things like broken bones or people who fell because of the emergency itself. But the emergency system in the US is not designed to meet an emergency and healthcare needs for a community for weeks at a time. Hospitals are not designed for that. And as hospitals close, particularly in more rural areas, healthcare and health access is moving further and further away, especially at that emergency level. And so it's becoming the responsibility of community clinics to really stand in and fill that gap when there is a prolonged crisis. And we're really seeing, again, not just from the acute crisis itself, but when the infrastructure fails and power goes out, how do individuals and patients keep their medications cold? How do you preserve vaccinations? How do you ensure that heat doesn't have a negative impact on your community? More people this year died after Hurricane Beryl in Texas from heat-related complications than from the storm itself. And this is really all, it's complex. It's a complicated mix of factors that are creating this. But what we can do as International Medical Corps and the niche we're filling in the United States is coming in and being able to provide that training, that scale, that experience to help communities, really be flexible and adaptable to whatever the disaster might be, but so that they can respond quickly.
Well, I want to give our audience a chance to ask any questions. So please make sure that you type any questions that you have into the chat, or maybe raise your hand and we can take you off, put your camera on so that you can ask the questions. But in the meantime, Sue, Erica mentioned sort of the increasing frequency and severity of disasters that we're seeing globally, but also here in the United States. And you've responded to, a number of our responses. I mean, is there anything in this response that was different or surprised you, or what was unique about this response?
Yeah, I think, to reiterate the size and magnitude, number one, right? It was so vast, so widespread. Typically a response, whether it's a hurricane or a tornado or an earthquake, is somewhat isolated to an area. This was spread out far and wide and lasted so long. We had a couple of big shelters going and then another fire, and we needed to start another shelter up. It was like, where do you go first? Where do you put your resources in stabilize the area with resources first? So that was a bit different with this one. And the other thing is the length of time. I referred to this earlier insofar as a response was usually a day, a few days, not as far as the response itself, but shelters, the need for housing. I live in Florida. I've been evacuated multiple times. The last place you want to be is in a shelter, right? Like long term, you go because you need it. But then as soon as you're able to, you have the resources, you get out. That isn't the case anymore. It's not a day, maybe a week. Now it's weeks, if not months. The event that happened in Hawaii, it's a year. The fires in LA, it was months where people are still unable to get back into their homes. So that's a dramatic difference, I think, that we're really starting to see and feel the impact of the size and magnitude of these events in the need for longer term support than ever before.
Right. I mean, we experienced that a little bit in North Carolina too. I mean, Helene was, again, the scale and the, wide geography that it impacted, and how we could help, and how, you know, where everyone was focused on North Carolina. I mean, there were communities across the Southeast that were heavily impacted and didn't get the support. I mean, but we were able to provide some of that support.
Absolutely. And
Yeah,
also, North Carolina, Asheville was not, they're not accustomed to having that kind of event.
yeah,
So
right.
different parts of the country getting hit with different types of disasters that their resources are not, to Erica's point, the training is so critical. The resilience, the emergency, it's so critical across the country because no one is immune. It was interesting right after, again, I live in Florida. We had 3 floods this year with hurricanes that sort of hit, but not completely. And I have family in North Carolina. I was speaking to my sister-in-law, and she said, "Oh, I feel bad for you because, you know, we moved to Asheville because we never get any, it's it's an area of the country that is not prone to natural disasters." And a week later, Helene hits. So I think the message is none of us is immune, right? That like with all of these situations, we're not immune. And being able to train and respond on a local level is it's so critical right now.
Right. Well, and I think that that's why our strategy is effective in the United States. I mean, maybe Erica, you could talk a little bit about that. I mean, we're a global humanitarian organization. We work in war zones and disasters. We're in Myanmar. We're in, South Sudan. We're in Sudan. We're in, all of these places, Ukraine. But it really is relevant to the United States. And maybe you could talk a little bit about that.
Sure. And Rebecca, I know you've heard me say this 1,000 times, but it's no different in the United States than it is anywhere else in the world, especially if it's happening to you. And so, there are communities across the United States where people don't have access to healthcare, where they are traveling hours and hours to see a specialist. When I first started much more globally to working within the United States, it was hard for me to comprehend how far and the distances that individuals had to travel, but to really access the care they need. And as that care moves further and further away, the Washington Post just this weekend had an article. 35% of the counties in the United States do not have a maternity ward or an obstetrician. So a third of the counties in the United States don't have access to that very basic type of care. And so when you see things like that, and when you think about that, there's some differences in the circumstances and the context, but it's really the same issues. Where's the transportation look like for you to get access to healthcare? Do you have to take off of work? Can you afford to do that? Do you have childcare? And these are all of the things that we've heard from everywhere we work around the world. And so for an organization like ours, we're doing the same kind of work. We're coming in, we're not seeking to replace the healthcare system. We're not seeking to augment or to set up a parallel system. We're really coming in and asking, how can we as an organization fill gaps, use best practices, help scale and innovate what's happening by bringing, especially in the United States where so much of healthcare is state run, there are lessons to be learned. And how do you bring that from one community to another? We have a program right now we're running in a mountain community in Puerto Rico around how do you manage your chronic disease during an emergency. And the demographics of that community look very much like some of the communities that were affected by Hurricane Helene in North Carolina. And we're going to be taking that training and scaling it and expanding it because we're able to do that and we have that knowledge. And so those are the kinds of gaps that we're looking to fill. And because we can move quickly, because we can provide clinical care when the situation and the disaster demands it, but we also have this enormous wealth of knowledge about how to help health facilities, clinics, health systems think about being more resilient, knowing it's not a one-time investment. Resilience, it's every day investing in that resiliency and putting those plans in place and then testing those plans and making sure that they are still fit for purpose and they work. And that's really the some of what we're doing. And then when we can, really helping to address some of those gaps in primary healthcare. If there are ways that we can come in and also help to plug those gaps in everyday healthcare, we're doing that as well.
Well, what are some of the things in addition to the trainings that you're working on? Like, what are some of the things that you are focused on for the future? And maybe it's sharing those lessons learned, right?
Right.
Between North Carolina and Florida and California.
Yes. So it is some of that. So we're doing quite a bit of, after the emergencies happen, a lot of what happens among the coordination bodies and at the state level or the county level are after action reviews. And we're actually being brought in to host a lot of those to be able to provide the framework for people to kind of think through what happened, what could they do differently. And we're able to use our experience to sort of inform what emergency plans might look like. But we've, over the last year in particular, but certainly across the last several years, have heard so much from these community health clinics that we work with and our partners. And one of the things that we hear about again and again and again is the need to invest in and leverage, the trust that community health workers or community caregivers, they go by a lot of different names, but have within the community. I think we all saw this during COVID-19 and the response where when people were able to go out into communities and talk to patients, and there was that level of trust that was established, we were able to really help advance public health and advance and sort of move towards good health outcomes. And that's something that we keep hearing is needed. And so we're really working across the country to really figure out how can we help community clinics really use community health workers, which is the model I think we think about a lot sort of in our overseas work, and we think about happening globally, but not here. But it's the same here. When you're hearing from a trusted voice, when you're hearing from somebody at the community, when community leaders are driving public health outreach campaigns, that's when they have the most success. And so we're really thinking through how we can strengthen that network nationwide and bring those lessons learned from one community to another.
Great. We have a question from one of our guests, Yuri. If you want to take yourself off mute and put your camera on and maybe introduce yourself and ask your question, we'd love to hear from you. Yuri?
Okay,
Are you there? There you are.
managed to unmute
Yeah, we
myself.
can hear you.
I don't know how to unvideo.
Okay.
How do I
Well,
do
don't
that?
worry about that. Go ahead and ask your question.
Okay, so hi, I'm dialing in from New York. Great to see you guys. Thank you so much for the update. My question is, my heart broke watching this all through January, and the unprecedented, Erica explained, Sue explained that the magnitude, the vastness, all that. But I'm wondering if all that learning, right, gaps observed, wealth of knowledge, not only at the grassroots level, but is there like a plan for like a white paper or a report that you could give to, under the current administration, whether it's still under FEMA or where that authority lies, because you need funding, you need changes, you need improvements, you need like a framework overhaul. So is there a plan for you to share all that you've learned coming out of this unprecedented crisis management?
Yes, thank you. Thank you. Great question. Thank you so much for the question. And yes, there is. And so there are a number of groups that we work with that operate at the national level where we're really talking this through. So one is the National Association of Community Health Clinics, which is an organization that really works with all of these individual clinics across the United States. And we've been working very closely with them to think through how we can collate some of this information and how do we best share it out. And so we participate in that network. We also participate in a network called the National Voluntary Organizations and Disasters organization, and they've got 50 state chapters. They have a national network as well, and so we're also talking with them about how we take this information and share it. And while we're not an advocacy organization ourselves, I think that some of what you're mentioning there, whether it's white papers, presentations, collation of data. That is something that we're looking to bring to national level audiences to really inform the way that we do emergency response in the U.S. We are also doing this on a state level. We're currently working with the state of California in particular to where we've run a statewide survey of all of the community health clinics, again, to really in non-disaster periods sort of ask them what they feel like the gaps in disaster management and response are, so that we can get that when they're kind of thinking of it, when they're not in crisis. And bringing together that data, and there is going to be a report that comes out through that. So in a number of different ways, we are really looking at how do we pull this information together to make it available to as many people as possible.
Thank you so much. I'm so glad to hear that. Maybe you should go, I don't know, testify before Congress or something.
Yeah, I mean, I think it's really important what you said, Erica, about state level coordination. I mean, I think with this administration, it is going to be the responsibility of the states to, respond to these disasters. And so, we do, Erica, you do have sort of a target list, right, of states, and really trying to prioritize and strengthen. I mean, starting with state, Florida, and Sue, you've been incredibly helpful there. But I think it's going to be all of those things. I think you're right, Yuri. We do need to kind of get the word out. Yeah.
Right. And as the funding shifts and as the responsibility does fall more to the states, I mean, we're really looking at, to your point, Rebecca, certainly California, Florida, Texas, and New York are four, kind of states that we're looking at how we can best help support and be part of their emergency response mechanism. And that's sort of one strategy. I mean, and then we have sort of strategies for states that may not be as sophisticated in their response mechanisms. So, really across sort of the greater Southeast, some of the states that are across the Midwest that maybe have not historically seen disasters of this scale and magnitude, or may, because of the way that disasters have been funded historically, just have the same level of response capability. And so we've got a little bit of a separate strategy for those states where we may be able to play a bigger or different or more hands-on role. So we're really looking at it in two different ways. But I think what's very clear and what we're hearing, we were at a Chamber of Commerce event last week, is that there's opportunity in looking at how disaster response is managed in the U.S. It does give local municipalities and states, more control potentially around those responses to make them more community driven, but it's a shift and it's a big one. And there is going to be a need for training and support and capacity as that shift is made.
Well, if there aren't any other questions, maybe we'll kind of wrap up with, maybe Sue, you could talk a little bit about, what was something reflecting on this that good that came out of it, or something that, you felt like a real positive from the response that you could share with our audience. No, you're still on mute. Oh, okay. Well, you go, Erica, and Catherine, can you get off mute? Oh, she's off. She's off.
I said the host would not allow you to unmute. I'm like,
sorry, my bad.
That's okay. We got it.
No worries. No worries. We're all good. You can hear me, right?
Yeah.
Okay.
Good. Okay. I think, the thing that we always walk away with is you always reflect on what did we do well and what could we have done better. And I think in this one, especially, what we did well was serve a very large population in a very unprecedented event, in something that I think they nor we were accustomed to doing insofar as Red Cross shelters. And I when I look at how much benefit was brought to the recipients, was brought to the most marginalized, and how much joy I saw in the residents that were really suffering a great loss, I think about that was something that I think we can all be proud of and say, with your support, we were able to do a tremendous job in one of the worst events, certainly that California has ever seen. And then when I look at what we can do better, it's build that robustness throughout kind of the community. And I think we're doing that. That's kind of our takeaway, you know, of what was learned, is that we all need to do a better job of building that resilience and the ability to deal with these events that I don't think are going to go away, unfortunately.
Erica?
I'm not sure I can say anything more eloquent than that. So I agree, but I guess I would just, one of our colleagues, and I know he didn't come up with this, but he often says that, JR, who some of you may have seen or know, you know, always says that people are sometimes the problem, but they're always the solution. And I think that that is especially true for this response, and really as we respond. I mean, the dedication and support of I think of International Medical Corps as an organization when this happened in the town that we are headquartered in the area that we're headquartered in, and to see our own staff and colleagues come out and want to help, to our donors who mobilized and wanted to help and were able to provide those resources, and the immense outpouring we had from volunteers to really sustain this, I mean, was just incredible. And it's for all of those, you know, when you're on the ground and you're doing the work and it's, you know, 18-hour days and you're not sleeping, it is because you're seeing how much everybody else is looking to put out there, and how much effort they're looking to put in. And so it's, like I said at the beginning, it's just really an honor to be able to do it.
Well, I mean, so many of the people on this call have been instrumental in supporting our work. And so, you know, let me echo what Sue and Erica have said. Thank you so much for your tremendous support. We appreciate you. You power the work of International Medical Corps and really make it possible for us to respond in this way and to have a long view of this, and to, you know, really strengthen and build capacity across these communities that have been so impacted by these disasters. And so thank you. Just want to thank you for your tremendous support, calling in today, joining us today. And we look forward to continuing to engage with you, and you know, happy to answer any further questions that you might have. And just thank you so much for joining us. Erica, Sue, thanks for participating, and we appreciate everyone, and thank you so much for your support. We'll see you on the next call. Thank you.